ठीक है. So iodotyrosine, when it attaches to the tyrosine, either one iodine will attach to a tyrosine of a thyroglobulin, which is called monoiodothyronine, or two may attach, which are called diiodothyronines. Okay, when one monoiodo combines with a diiodothyrosin, we get a tetraiodothyronine or a T3 coupling हो जाती है. Or when a diiodo combines with a diiodo, you get a tetraiodothyronine or a T4 or a thyroxine. ठीक है. आयोडीन 1 बाइंड हुआ, 2 बाइंड हुए, अगर 2 एक के साथ यूनाइट हुआ तो 3 बन गया, 2 2 के साथ यूनाइट हुआ तो 4 बन गया. ठीक है. Circulating thyroid hormones, T4 and lesser amounts of T3 are released into the systemic circulation, where most of them are reversibly bound to circulating plasma proteins. Now, larger amount of T4 comes in the circulation, smaller amount of T3 comes in the circulation, and in the circulation they are bound to the thyroxine binding globulin and transthyretin. These are the circulating proteins. The work of the circulating proteins is that to keep the we keep this thyroid hormones readily available to the tissues. Okay? But also they keep the unbound or the free hormones in the concentration in within narrow limits. Available भी है लेकिन available नहीं है. जब जो है free, when it becomes free, when the protein is lost from it, then it becomes free T3 or free T4. That has to be maintained at a very narrow limit. The concentration has to be really controlled. ठीक है. तो free नहीं होता वो, लेकिन bound form में move करता रहता है so that it is easily available to the tissues. In the periphery, the majority of free T4 is deiodinated to T3. ठीक है. So for the bound form T4 and T3, larger amounts of T4 are present in the circulation. When the bound ones are separated from the binding proteins, they become free T4, free T3. A larger amount of free T3 is present in the circulation as compared to free T4. Okay? The T3 binds more readily to the receptors in the target cells with 10-fold greater affinity than T4 and greater activity. So the more active, the more greater affinity is in T3 as compared to T4. Regulation of thyroid hormone secretion. How is it regulated? Any form of stress or any cold or anything which is felt by the brain centers, it gives the signal to the hypothalamus. The hypothalamus secretes a substance which is called TRH, which is called the thyrotropin releasing hormone. This TRH acts on the anterior pituitary to cause the release of TSH, which is the thyroid stimulating hormone. This TSH acts on the thyroid gland to cause the secretion of thyroid hormone. See, this is from if there is cold exposure or any such factor that causes stimulus to the hypothalamus. The hypothalamus secretes TRH, which acts on the anterior pituitary to secrete TSH, which acts on the thyroid gland to produce the thyroid hormones. Now, when there is excess of thyroid hormones, this thyroid hormone by negative feedback inhibits TSH, and this by negative feedback inhibits TRH. So these thyroid hormones, they can inhibit TSH and they can inhibit TRH by negative feedback. So this is how they control thyroid hormone secretion. Now, the effects of thyroid hormones, it has got diverse cellular effects. We discussed insulin. We discussed that insulin was an anabolic hormone, was anabolism for all the things. But here, thyroid hormone is a catabolic hormone for carbohydrate and lipid metabolism. Okay? There is causes carbohydrate and lipid catabolism. Then, for protein, it causes protein synthesis. The net result is increase in basal metabolic rate, and it plays a critical role in fetal and neonatal brain development. Very, very important. We will discuss this consequently, how it helps in the brain development of the fetus. The functions of the thyroid gland is inhibited by many chemical agents, and they are called goitrogens, and they suppress T3 and T4 synthesis. So the level of TSH increases, and when TSH increases, it causes hyperplastic enlargement of the thyroid gland, and this is called a goiter. So there are many chemical agents. When it causes less T3, T4, increased TSH will cause the increased hyperplasia of the thyroid gland and goiter formation. Antithyroid drug propylthiouracil inhibits the oxidation of iodide and blocks the production of thyroid hormones. These antithyroid agents have got, each agent has got different ways in which it will block the thyroid hormone synthesis. This you will do in your pharmacology. Now we come to thyrometabolic disorders. There are two thyrometabolic disorders. One is hypothyroidism and one is thyrotoxicosis. Okay? Hypo and hypothyroidism, you understand, less secretion of thyroid hormones. Thyrotoxicosis is often used synonymously with hyperthyroidism. Okay? Hyperthyroidism and thyrotoxicosis often used synonymously. They're used in a similar fashion, but there is a slight difference between the two. What is the difference? Thyrotoxicosis, all the symptoms of increased thyroid hormones, the biochemical changes, the physiological changes, all the changes which occur, the symptoms which occur due to increased thyroid hormones is thyrotoxicosis. The symptoms, the hypermetabolic state. Okay? So that is thyrotoxicosis. If the thyrotoxicosis is due to increased secretion by the thyroid gland, it is hyperthyroidism. Okay? What is the difference? It's not always necessary. Most of the time, there is increased secretion by the thyroid gland, which causes the symptoms of thyroid. Okay? So that is hyperthyroidism causing thyrotoxicosis. But sometimes what happens is, if there is thyroiditis, patient has got thyroiditis, there is increased secretion of the gland is not there. There is already stored hormone within the gland which is just released. Okay? So that is thyrotoxicosis without hyperthyroidism. Or there is some ectopic gland, ectopic area where the thyroid hormone is being secreted, not the thyroid gland itself. So there is thyrotoxicosis, but hyperthyroidism is not there. Okay? So thyrotoxicosis are the symptoms which are produced, and if it is due to increased secretion by the gland itself, then it is called hyperthyroidism. So there is a slight difference between the two. Okay? Is it clear? I hope it's clear to everyone. If it is not, you can always ask me, and please unmute your phones, ask me, stop me anytime you have any questions in the whole of the lecture. All right? Okay. Now we come to hyperthyroidism can be primary. If there is, in endocrinology, if the gland which is causing the disease is abnormal, that is primary disease. Okay? If there is, if the main gland is normal, but there is something other than the gland, then it is called secondary. Usually in case of those hormones which are stimulated by the pituitary and the hypothalamus, then the secondary means the pituitary. Okay? And tertiary means the hypothalamus or scrotal. So primary is due to intrinsic thyroid abnormality. Secondary processes outside the thyroid, like a TSH secreting pituitary tumor would be called secondary hyperthyroidism. The three most common causes of thyrotoxicosis are due to hyperfunctioning of the gland. There can be diffuse hyperplasia associated with Graves' disease. 85% of most of the hyperthyroidism or most of the thyrotoxicosis is due to Graves' disease. There is diffuse hyperplasia, or it can be due to hyperfunctioning multinodular goiter, or it could be due to hyperfunctional adenoma of the thyroid. The clinical cause of thyroid disorder, there is hypermetabolic state due to excess thyroid hormones and overactivity of the sympathetic nervous system. There is increase in basal metabolic rate. The skin is soft, warm and flushed due to increased blood flow and peripheral vasodilation to increase the heat loss. Patient feels hot, warm, so the skin is also soft, warm and flushed because of increased blood flow. There is heat intolerance, there is sweating, there is characteristic weight loss despite increased appetite. We did this in our diabetes also. Two conditions in which there is weight loss but increased appetite. Patient is eating more, but he is losing weight in diabetes or in thyrotoxicosis. Cardiac manifestations, they are earliest and the most consistent feature. There is increased cardiac output, tachycardia, palpitations, cardiomegaly, arrhythmias, particularly atrial fibrillation. This is more commonly seen in older patients. Congestive cardiac failure may develop, thyrotoxic or hyperthyroid cardiomyopathy. There can be left ventricular dysfunction and low output cardiac failure. Overactivity of the sympathetic nervous system leads to tremors, hyperactivity, anxiety, inability to concentrate, insomnia, thyroid myopathy, proximal muscle weakness, and decreased muscle mass. Ocular changes, wide staring gaze, lid lag due to sympathetic overstimulation of the muscles of the eye. The gaze becomes wide and staring. Lid lag is that do it when you see yourself in the mirror. When you're looking up, your lid is like this. When you start looking down, your upper eyelid goes down with your eye, right? So in these people, there is a lid lag. There is a small delay before the upper eyelid goes down. When you look down, the upper eyelid, there's a delay in the going down of the upper eyelid due to sympathetic overstimulation of the superior tarsal muscle. And this is along with the levator pulmonary superioris, and both of these muscles, there is overstimulation of them, due to which there is a lid lag. However, true thyroid ophthalmopathy associated with proptosis is seen only in Graves' disease. When we do Graves' disease in the next lecture, there is a typical eye pattern, proptosis, the bulging of the eyeball, the protrusion of the eyeball. That is seen only in Graves' disease. Here, it is just a lid lag. In the GIT, there is hypermotility, malabsorption, and diarrhea. Skeletal system stimulates bone resorption, increased porosity of cortical bone, leading to osteoporosis and increased risk of fractures. There is also atrophy of the skeletal muscle. This is a short, small picture to show you the different features of hyperthyroidism: the intolerance to heat, fine straight hair, bulging eyes, facial flushing, enlarged thyroid, tachycardia, increased systolic blood pressure, breast enlargement, weight loss, muscle wasting, localized edema, menstrual changes, diarrhea, tremors, finger clubbing. All this can be seen in case of hyperthyroidism. There is something which is called thyroid storm. This is an abrupt onset of severe hyperthyroidism, usually seen in patients with, who have Graves' disease. What happens is that there is some infection, there is some stress, some surgery, because of which there is acute elevation of the catecholamines. And because of that, the thyroid secretion is also increased, and a patient goes in thyroid storm. This is a medical emergency, and patient can die of cardiac arrhythmias. So a patient with Graves' disease, if you have to have their surgery or any other thing, you should be alert about this. Apathetic hypothyroidism, this is the thyrotoxic hypothyroidism which is occurring in the elderly people. Because of the old age, because of the comorbidities, the features of the thyrotoxicosis do not appear. The patient doesn't complain of anything and the features are not there, but the patient can come to you with atrial fibrillation or something like that. And the diagnosis is done by laboratory and due to unexplained weight loss or worsening of cardiovascular disease. There could be just unexplained weight loss, cardiovascular disease is worsened, or the patient may go in atrial fibrillation, and that you should see whether the patient has got a hyperthyroidism. Laboratory workup. Serum TSH is the most useful screening test for hyperthyroidism. And there are two types of tests. One is called a screening test and one is called a confirmatory test. Screening test is done for almost all people because whenever a patient goes to the doctor for any miscellaneous thing, most of them, they will write a TSH, serum TSH. This is as they use as a screening test, which is done for a whole population of people. Okay? A screening test should be cheap, should be easily accessible, and it is done for a large population of people. That's called a screening test. When you find TSH abnormal in a screening test, then you will do the confirmatory test. Okay? So why TSH? Because TSH is a very sensitive test. Small changes in the thyroid hormone levels and the TSH is the first thing which will go abnormal. So very good screening test. 15 days before, anything, its slightest change and the TSH will be upset. A low TSH, if it is present, then you confirm with a free T4, which can be increased. Some cases, the free T4 may be normal or may be decreased, but still you find the symptoms of thyrotoxicosis. So that could be a T3 toxicosis. Some patients have increased levels of T3, and which causes symptoms of thyroid disease, and this is called T3 toxicosis. This disease is more common in geographical areas associated with iodine deficiency. Now, for secondary hyperthyroidism, what do you do? If it is due to pituitary or hypothalamic disease, here the TSH level will be normal or raised. Now there is increase of TSH causes increase of thyroid hormones. So, but here they are saying the TSH may be normal or raised. Why normal? See, when the patient has got hyperthyroidism, the free T4 will be raised. Because of the free T4, it should go to the pituitary and give a negative feedback, and the TSH should be reduced. For normal, for primary hypothyroidism, T4 will be raised, which will give a negative feedback on the TSH, and the TSH should be low. Right? Hypothyroidism, we know this, that T4 is raised and TSH is low. Okay. But some cases are there in which the TSH may be normal. So you get confused, now what is this? So that when I used to study, I used to remember it like this, that this TSH is abnormally normal. It should be low, but it is normal. So it is abnormally normal, right? So in case of secondary hyperthyroidism, TSH may be normal also, but TRH raised, TSH should be low. If it is not low, that means it is secondary. Is it clear? Okay, and for that what you do is that you do a TRH stimulation test. TRH, thyroglobulin releasing hormone, is injected. And first you do a baseline TSH, find out what the TSH level is of the patient. Then you give the patient TRH, inject TRH. It should, if there is an increase in the TSH due to TRH, that means the pituitary control is normal. Giving the hormone, TSH is increasing, that means pituitary disease is not there. But if they give the hormone, the TSH does not show much response. That means the control is lost. Loss of controls means there is a pituitary disease. Okay? A normal rise in TSH after administration of TRH excludes secondary hyperthyroidism. Is this clear, everyone? Any question? Any query? Now you have diagnosed thyrotoxicosis. Now you have to diagnose the etiology of it. So what you do is you give radioiodine to the patient, radioactive iodine to the patient, and you see the uptake of the radioactive iodine. In Graves' disease, there is diffused increased uptake of the radioactive iodine by the whole gland. In toxic adenoma, there is one adenoma. So there is a solitary nodule is taking up all the increased uptake in a solitary nodule. Or if there is thyroiditis, inflammation, there will be decreased uptake by the gland. Any query on hyperthyroidism? Please unmute your phones and unmute your mobiles and ask me. Okay. Now we come to hypothyroidism. This is caused by a structural or functional derangement that please explain TRH test. See, TSH pituitary disease में क्या होता है कि pituitary function is lost. ठीक है? Pituitary does not उसको control उसका lose हो जाता है. ठीक है? Now what you do is that you TS in secondary hyperthyroidism, TRH will be high. Hyperthyroidism है तो TRH high, sorry T4 high होगा, TSH low होगा अगर पिट्यूटरी डिजीज है, सॉरी प्राइमरी डिजीज है, ठीक है ना। अगर आपके पास पेशेंट आया T4 रेज्ड है, ठीक है, एंड यू डू TSH अगर उसका जितना भी है, यू गिव द पेशेंट एडमिनिस्टर TRH, बेसलाइन TSH करवा लो, यू एडमिनिस्टर TRH टू द पेशेंट, इंजेक्ट TRH, ठीक है। TRH का काम क्या है कि पिट्यूटरी स्टिमुलेट करवाना, राइट। सो लॉस ऑफ कंट्रोल means there is disease. Remember this. TRH आपने एडमिनिस्टर किया, TSH को बढ़ना चाहिए था। अगर TSH नहीं बढ़ा, इसका मतलब है कंट्रोल लॉस्ट है। अगर कंट्रोल लॉस्ट है, इसका मतलब है पिट्यूटरी डिजीज है। अगर तो यही बात है कि अगर FT4 बढ़ा हुआ था तो TSH को लो होना चाहिए था, ठीक है। अगर लो नहीं है और नॉर्मल भी है, तब भी पिट्यूटरी डिजीज। Have you understood? कौन है ये? Someone has texted me. ठीक है, now it's all right? Okay. Ma'am, can you explain the difference between primary and secondary hyperthyroidism lab results again? ठीक है. Primary hyperthyroidism, gland में से secretion ज़्यादा है, T4 बढ़ा हुआ होगा. Thyroid hormones T4 बढ़े हुए होंगे, और because of the T4 increased T4, it will stimulate the pituitary TSH कम हो जाएगा. That is a primary hyperthyroidism. ठीक है. Secondary hyperthyroidism में क्या होगा कि TRH बढ़ा हुआ है, TSH होना बढ़ा हुआ चाहिए। अगर इसका थायराइड डिजीज है ना, तो थायराइड पिट्यूटरी डिजीज है ना, तो पिट्यूटरी स्टिमुलेट कर रहा है, जिसकी वजह से थायराइड बढ़ रहा है, ठीक है। पिट्यूटरी स्टिमुलेट तो कर रहा है, लेकिन पिट्यूटरी आइडियली तो ये होना चाहिए कि ये भी होता है, मोस्टली बहुत दफा ये होता है कि TSH भी बढ़ा हुआ है और TRH भी FT4 भी बढ़ा हुआ है, दोनों चीजें बढ़ी हुई है, ठीक है। दैट इज सेकेंडरी डिजीज. But there are cases in which the TSH may be normal, but TSH is abnormally normal. If high T4, the TSH should be low, but high T4 with a normal TSH means pituitary disease. और अगर आपको इसको टेस्ट करना है, होता तो नहीं है TRH stimulatory test, लेकिन it's written in your book, so I'll explain it to you that when you give TRH to this patient, TRH, the work of TRH is to stimulate the pituitary to produce TSH, right? Baseline TSH था supposing 2, ठीक है। हमने TRH दिया तो TRH देने से TSH जो है वो 2 के बदले 6 हो गया, ठीक है। That means the TRH has stimulated the pituitary and the pituitary hormones have gone up, right? That means control is there. अगर TRH आपने एडमिनिस्टर किया और पिट्यूटरी अगर 2 था तो वही रहा, 2 रहा, 2.5 हो गया, दैट मीन्स नाउ द कंट्रोल इज लॉस्ट। TRH जो है वो पिट्यूटरी को कंट्रोल नहीं कर रहा, इसका मतलब है कि पिट्यूटरी में कोई डिसीज है। सही है, समझ आया? यस, अंडरस्टूड? ओके, गुड, ठीक है, ओके। Now, hypothyroidism, caused by structural or functional derangement that interferes with the production of adequate levels of thyroid hormones. Any reason when there is decreased secretion of thyroid hormones is hypothyroidism. It can be subclinical or overt. Very common subclinical hypothyroidism is also very common. मतलब कोई symptoms नहीं है, कोई features नहीं है, बस उसको hypothyroidism, TSH उसका बढ़ा हुआ है. Prevalence increases with age, more common in women than in men. It can be primary or secondary. ठीक है, hypothyroidism भी similar. अगर पिट्यूटरी से हो रहा है तो प्राइमरी है, अगर ऊपर से हो रहा है, सॉरी मैं क्या तुम लोगों को कंफ्यूज कर रही हूं, अगर हाइपोथायरॉयडिज्म ग्लैंड से हो रहा है, थायराइड ग्लैंड से हो रहा है तो प्राइमरी है, अगर पिट्यूटरी से हो रहा है या हाइपोथैलेमस से हो रहा है तो फिर वो सेकेंडरी हो जाता है, ठीक है। Causes of hypothyroidism: primary, genetic defects in thyroid development. thyroid hormone resistance syndromes, post-ablative autoimmune hypothyroidism, iodine deficiency, drugs, and congenital biosynthetic defects. Secondary causes of hypothyroidism, pituitary failure, hypothalamic failure, but they are rare. Primary hypothyroidism accounts for the majority of cases and can be accompanied by enlargement of the thyroid gland, which is called goiter. Primary hypothyroidism can be congenital, iatrogenic, or autoimmune. Okay? Okay. Congenital hypothyroidism. It is most commonly due to endemic iodine deficiency in the diet. Used to be more common, but nowadays we have supplemented foods with iodine, especially iodine supplemented salt is taken. So congenital hypothyroidism has become a little less. But it can also be due to inborn errors of thyroid metabolism. We did all the steps of thyroid hormone synthesis. Anywhere where there is a deficiency of any of those steps can lead to hypothyroidism. Now, there is something which is called cretinism. Hypothyroidism which develops in infancy or childhood, if untreated, will cause cretinism. Vast majority, most of these have congenital hypothyroidism. They have few clinical manifestations. That means the child who is born, at that time, not much changes are seen. You can't diagnose this patient on seeing or on this behavior that the patient has got hypothyroidism. So all the signs and symptoms are there and they are so subtle that can be easily missed. So here we discuss screening tests. Now, all newborns should be screened on the 3rd or 4th day of life by TSH levels. This has been started in our hospital that all the newborns, they should be screened. All newborns born in the whole country or the whole world, they should be screened for TSH levels. This TSH level should be done for them on the day 3 or the day 4 of their life. Okay, the importance I will show you. Cutoff limits for TSH, normal less than 15, borderline 15 to 30, hypothyroidism greater than 30. Maternal history and thyroid function tests should be performed to diagnose transient hypothyroidism. Now remember this, normal 15, borderline 15 to 30, hypothyroidism greater than 30. This is the levels for day 3 of life of the baby. Clinical features, there are a whole list of clinical features which may or may not be there. Constipation, lethargy, prolonged jaundice, hypotonia, umbilical hernia, large fontanelles, slow movement, hoarse cry, feeding problems, macroglossia, dry skin, hypothermia, a whole list of features are there. If untreated congenital hypothyroidism, the patient may develop cretinism, they may develop mental retardation and stunted growth. So this is a very, very treatable disease. If you measure the TSH level, if you start the treatment, if you don't give the treatment to the patient, you ignore it, you don't screen the patient, for life the patient life is destroyed. The patient is mentally retarded, physically retarded. You destroy the life of this baby. But if you screen the baby, you treat the baby immediately, the baby can have almost a normal life. So this is a very, very treatable disease, and just the important thing is you screen the baby at day 3 of life. It's very important. Okay. Normally, maternal T3 and T4 cross the placenta and are critical for fetal brain development. The mother secretes the T3 and T4 and it crosses the placenta and goes for fetal brain development. But if there is any maternal deficiency, thyroid hormone deficiency, before the fetal thyroid gland is formed, then mental retardation will occur. So it depends कि utero में कब उसको deficiency मिली है. Early pregnancy, fetus thyroid gland is not developed. At that time, if the mother develops thyroid deficiency, the fetus will have severe mental retardation. But if the fetal thyroid gland has developed and now the maternal fetal mother develops hypothyroidism, then what will happen? That fetal gland is already there. Fetus will start producing thyroid hormones and does not affect the brain development of the fetus. So it depends on what time in utero the baby gets exposed to hypothyroidism. Ideally, treatment should be initiated in an infant with a clearly positive screening test as soon as confirmatory blood sample have been drawn, pending the results. If I said 15 normal, 15 to 30 gray zone, 30 congenital hypothyroidism. So if you get a blood TSH level of 30, take the blood sample for the confirmatory test and start the treatment. Don't wait for the result of the blood test. If the patient is in the borderline state, 15 to 30, you can wait for the confirmatory results and then you can make your decision. But treatment should never be delayed beyond 18 days of time. 18 days, 15 days, you should start the treatment before that, because if you delay it, the patient will develop mental retardation. Iatrogenic hypothyroidism, this can be caused by surgical or radiation-induced ablation of the thyroid gland. If there is treatment for hypothyroidism, you do a surgery, total thyroidectomy. You may cause hypothyroidism, or for the treatment of hypothyroidism, you give the radioiodine ablation. You destroy the whole thyroid gland and it will cause hypothyroidism. Or there is exogenous irradiation, radiation to the neck due to any other reason can cause hypothyroidism. Certain drugs which are used to treat non-thyroid conditions like lithium, which is used in case of, it's an antipsychiatric drug used in psychiatry, that can cause hypothyroidism. Autoimmune hypothyroidism, details of this we will do in the next lecture, but it is, just I want to tell you that it is the most common cause of hypothyroidism in iodine sufficient areas of the world. If there is iodine sufficiency, there is no iodine deficiency, then most commonly it is autoimmune hypothyroidism. Majority of cases are due to Hashimoto thyroiditis, and as you know, with all autoimmune diseases, there are circulating autoantibodies which will be present in the blood, antimicrosomal, antithyroid peroxidase, antithyroglobulin antibodies. Okay? Antibodies will be there. The thyroid is typically enlarged or goitrous. Autoimmune hypothyroidism may occur in isolation alone or in conjunction with autoimmune polyendocrine syndrome, APS1, APS2. This we will discuss when we discuss the adrenal gland, because this is a syndrome of many different endocrine abnormalities, APS1 and APS2. So in that also hypothyroidism can be present. Secondary or central hypothyroidism due to deficiency of TSH or TRH. Okay? Uncommon but can be there if there is some pituitary disease, pituitary tumor, postpartum pituitary necrosis, trauma, non-pituitary tumors are there, it can cause this, or some hypothalamic damage from tumors, trauma, radiation, infiltrative diseases, so it can cause secondary hypothyroidism. There is something which is called thyroid hormone resistance syndrome. There are mutations in the thyroid hormone receptors so that the hormone cannot bind to it. Okay? So receptors, the hormones are there, but there is resistance. There is resistance to thyroid hormones despite high circulating levels of T3 and T4. The hormones are there in the body, but the patient is resistant to that, like we did with insulin resistance. So the T3, T4 may be raised, and in this case, TSH also tends to be high because the T3 and T4, the receptors are not there. So the pituitary also, it keeps on stimulating the TSH also. So TSH is high and T3, T4 are also high. Myxedema is hypothyroidism developing in the older child or adult. Older children show signs and symptoms intermediate between those of a cretin and an adult with hypothyroidism. Okay? In the adult, the disease develops gradually and may take years before being clinically significant. There is slowing of physical and mental activity, generalized fatigue. Most of these features are opposite to hyperthyroidism. Generalized fatigue, apathy, mental sluggishness, which may mimic depression. Speech and intellectual functions are slowed. Patient is listless, cold intolerant, frequently overweight. There is decreased sympathetic activity leads to constipation, decreased sweating. Skin is cool and pale due to decreased blood flow. Reduced cardiac output causes shortness of breath, decreased exercise capacity. And it promotes an atherogenic profile. Hypothyroidism causes atherosclerosis and abnormal lipid levels, increase in total and LDL cholesterol, which may contribute to the cardiovascular mortality. There is non-pitting edema, broadening and coarsening of facial features. I'll show you the picture. Facial features are broadened, coarsened, and there's enlargement of the tongue, deepening of the voice. Why all these things occur? Due to deposition of glycosaminoglycans and hyaluronic acid in the skin, the subcutaneous tissues, and a number of visceral sites. These matrix substances, intracellular matrix substances, they cause the broadening and the coarsening feature. And there's non-pitting edema. Edema is there, which is non-pitting in nature. Patients with unexplained increase in weight and hypercholesterolemia should be assessed for hypothyroidism. So if there is increase in weight, the patient is showing hypercholesterolemia, you should assess for hypothyroidism. And again, TSH is the most sensitive screening test. In primary hypothyroidism, TSH is increased due to loss of negative feedback by the thyroid hormones. TSH, the thyroid hormones are low, so the TSH will be keep on stimulating. So TSH will be increased. In hypothalamic disease, TSH is not increased. TSH is low, which causes the thyroid hormones to be low. T4 is decreased in hypothyroidism due to any cause. Okay? Have you understood the hormone play over here? See, this is a patient with, before treatment, look at the thick nose and thick lips and all the things there. And look at this. This is a broadening and the coarsening of the facial features. Again, a short to show you intolerance to cold, receding hairlines, facial and